us today. We are recording today's webinar and it will be posted up on our website next week. We'll send out a link so everyone can view this if they would like to. But today we are presenting on sexually transmitted infections. What is new in 2022 for OBGYNs? Next slide, please. The webinar is sponsored today by the New York City STD Prevention Training Center, which is a CDC-funded grant that provides clinical provider education around sexual health issues. Next slide, please. We are offering continuing education today. If you have any questions during the webinar, there's a Q&A tab at the bottom of your screen. You can address your questions there. Next slide, please. For continuing education, you will receive an email after today's webinar with instructions on how to obtain your CME and CNE. The deadline for obtaining this is May 28th. Next slide, please. Now I'd like to get started by introducing our speakers. Our first speaker today is Dr. Gail Burstein. Dr. Burstein is a pediatrician specializing in adolescent medicine and is the Erie County, New York, Commissioner of Health and a clinical professor of pediatrics at the University at Buffalo, Jacobs School of Medicine. Dr. Burstein participated in the writing of the 2021 CDC STI treatment guidelines as a work group member. She participates in writing national adolescent healthcare guidelines and policy papers and has been published in many scientific peer-reviewed journals. Our second speaker for today is Dr. Lonnie Tall, who is a clinical assistant professor of obstetrics and gynecology at the Jacobs School of Medicine at University of Buffalo. She obtained her medical degree from Vanderbilt University, completed residency at Pennsylvania Hospital in Philadelphia, and last year graduated from a 2-year fellowship in complex family planning at Washington University in St. Louis. Having spent time working in Title X family planning clinics and being the daughter of an infectious disease specialist, Dr. Tall has a particular interest in sexually transmitted infections and is looking forward to discussing these topics today with her new ACOG district. We'd also like to say a special welcome to ACOG members who are joining us today.
Thank you. So I'm Gail Burstein, as Gary mentioned, the Erie County Commissioner of Health and a pediatrician and an adolescent specialist at UB's Jacobs School of Medicine. So today, in the next 5 minutes, I'm going to give you an overview of syphilis, gonorrhea, and chlamydia in New York State and New York City. Next, please. So overall, the New York State and New York City STI situations are not good. First, I'll present New York State STI surveillance data, excluding New York City, followed by the New York City data. So as you can see from this slide, that there, after 5 consecutive years of reported chlamydia cases increasing, in 2020, overall chlamydia cases decreased. We believe those numbers reflect pandemic-related circumstances, such as reduced number of asymptomatic females accessing preventive care where chlamydia screening occurs, and clinical staff diverted to COVID-related work instead of sexual health work. However, among females, there was a 60% increase in reported gonorrhea cases and a 20% increase in reported syphilis cases, and subsequently a 20% increase in congenital syphilis cases. Next, please. So this slide maps out where congenital syphilis cases occurred in 2020 by primary and secondary syphilis diagnoses of women of reproductive age. So it makes sense that the more congenital syphilis cases occurred in counties with a greater number of primary and secondary syphilis diagnoses among females of reproductive age. The most common missed congenital syphilis opportunity occurred when mothers did not receive timely prenatal care or syphilis testing. Next, please. So let's move on to New York City STI epi. Overall, after several years of reported STI increases in New York City, large decreases were observed in chlamydia and gonorrhea rates in 2020 compared to 2019. The decrease in selected STI rates was likely related to the COVID-19 public health emergency also, with reduced STI detection due to a combination of reduced screening and testing and decreased transmission. However, among reported cases of gonorrhea, chlamydia, and syphilis, notable inequities persisted, and underscoring the need to improve access to timely, high-quality sexual health care services for all New Yorkers. Next, please. So this slide shows the numbers, which are in green, and the percentages, which are in blue, of the congenital syphilis-related pregnancies related to syphilis acquired during pregnancy in New York City from 2010 to 2020. And symptoms of chronic public health and medical health, lack of resources. These numbers remain unacceptably high. Missed opportunities for preventing congenital syphilis where we can make a difference include lack of prenatal care, inadequate syphilis treatment during pregnancy, missed syphilis screening during pregnancy, and errors in the public health response to syphilis lab results. Next, please. So this slide presents the demographic data for pregnant women in New York City linked to congenital syphilis cases from 2010 to 2020. And that illustrates that, that there are many inequities persist over the past decade, highlighting the need to improve access to timely, high quality sexual health care services and prenatal care, again, for all New Yorkers. So pregnant women linked to congenital syphilis cases in New York City were more likely to be in their 20s, Black or Hispanic Latina, and living in high poverty areas in New York City. Next, please. So overall, syphilis is increasing among women in New York City, especially among women of color. Congenital syphilis is a sentinel event because it represents systems failures, usually at multiple levels, including patient, provider, hospital, and the public health system. And this has really been a chronic systems failure. So people who are pregnant in New York City must be screened for syphilis 3 times during pregnancy. So first at the first prenatal care exam, that's a New York State law. And then the second time is during the 3rd trimester between 28 to 32 weeks. That's a New York City regulation. And then also it's a bill that is going through the New York State and New York Assembly and Senate. And then thirdly is at delivery, and that's also a New York State law. Next, please. So this slide presents the number of reported new HIV diagnoses among females in New York State and New York City between 2011 to 2020. So the good news is that the universal HIV screening and PrEP has really made a difference. You can see that overall in the past 10 years, the number of new reported HIV diagnoses among women in New York State and New York City has decreased. Women between the ages of 25 to 54 years old account for the largest percentage of females newly diagnosed with HIV in New York State and New York City. In 2020, while the number of new HIV diagnoses among female declined among almost all the age groups, the 25 to 34-year-old women increase in new HIV diagnoses. And so again, that's women of reproductive age. So now that's our World War II tour through New York State and New York City STI EPI. I'm going to turn the talk over to the really interesting part, to the STI treatment and testing, to Lonnie Tao for updates. Thank you.
Thank you, Dr. Burstein. Hello, everybody. I'm Lonnie Tall. I'm an OBGYN at University of Buffalo, and I'm looking forward to sharing these STI clinical updates with you all. I have no relevant financial relationships. So the impetus for this talk is that last year, the CDC published their updated guidelines for the diagnosis and treatment of sexually transmitted infections. If you're like me and you rely heavily on apps, just please be aware the current app is the 2015 guidelines, so you should not be using that. The 2021 app is in development, but in the meantime, you should either memorize everything I tell you today or go to the CDC website when you need to treat patients. So here's an outline. I'm going to go through each one of these entities and explain what's new and also explain the rationale behind the new recommendations, because if you're like me, that's how I can get things to stick in my brain. So first we'll start with syphilis. And as we heard from Dr. Burstein, cases are on the rise, including congenital syphilis, which is a major public health issue. As OBGYNs and other sexual health providers, we're on the front line of screening, diagnosis, and referring for treatment. So it's really important that we are on top of this stuff. I want to review a little bit about diagnosis because this is one of the trickier ones. So diagnosis requires both a non-treponemal and a treponemal test. A non-treponemal test is like an RPR, which is really testing the body's immune response. It's non-specific, which means it also has a high false positive rate. A treponemal test is testing specifically for syphilis antibodies. The traditional algorithm, which most of us are probably doing, is the RPR first and then a confirmatory test. There's also the reverse algorithm, which starts with the treponemal test and then goes to an RPR or a similar non-treponemal test. The treponemal tests are valuable because they are reported as titers, which we follow to determine treatment success. And the treponemal tests are valuable because they are so specific, but they often stay positive for life. So ultimately, you need to know both tests, including the titer and a patient's history to understand their disease status. And I will say, I find all of this quite confusing, and therefore I recommend as best practice to make friends with infectious disease colleagues, the lab, or the health department to help manage positive results. In addition to just routine screening, we might also have patients coming in with symptoms that make us want to test for syphilis. And remember that classically, primary syphilis is a single painless chancre, but we're appreciating more that atypical presentations are common. A large proportion of folks will actually have multiple lesions, and many might also have painful lesions. Definitely something we want to be considering is a diagnosis of syphilis if someone has an ulcer and their HSV swab is negative. And remember, if they come in with symptoms that are relatively new and we send an RPR that day, it might come back as a false negative because it can take a few weeks to turn positive. So we should be considering bringing back our patients with ulcers to review their results and possibly retest if we don't have a diagnosis yet, or consider starting instead of with that non-treponemal test, like an RPR that takes some time to turn positive, start with a treponemal test, like an immunoassay, which will turn positive sooner. The treatment for syphilis is still the penicillin G based treatment regimens, depending on their stage of infection. For folks with a penicillin allergy, we can treat with doxycycline for 2 weeks. For pregnant folks, the recommendation is still desensitization so that they can get treated with penicillin. And you'll see in this top box, which is just a screenshot from the CDC guidelines, the asterisk, which says when you're treating, recommendations for treating syphilis among pregnant people are reviewed elsewhere. When you go to elsewhere, it says just treat the pregnant person with the penicillin G regimen for their stage of disease, but there is a caveat I'm going to get to. So syphilis in pregnancy, we discussed this, but it's super, super important, so I'm going to review it again. Everyone should be tested 3 times in pregnancy, at their new OB, again around 28 weeks, and then at delivery. And probably most of us are doing this and routinely doing a 3rd trimester screening. There are sort of mixed recommendations about risk-based screening, but really we should be doing universal 3rd trimester screening. So we're not trying to figure out who's high risk and who's low risk, but just screening everyone in the 3rd trimester. If a patient is diagnosed after 20 weeks with syphilis, then they should get a detailed ultrasound, which will be looking for evidence of fetal or placental syphilis, and some of those signs are listed here. It's also recommended to get repeat testing at delivery for any stillbirth greater than 20 weeks. I will say, as a complex family planning specialist, this is something I have definitely missed a lot in my practice, which I'm going to be changing going forward when I get referrals for IUFDs between 20 and 24 weeks. Be making sure to get syphilis on those. And then this is a little bit more for our pediatrics colleagues, but Neonates should not be discharged from the hospital without a maternal RPR result. So not a pending test, but a result. And this just might affect us as we're trying to get people out the door on postpartum day 1. They need to have that result done. The treatment in pregnancy, a reminder that adequate maternal treatment is the penicillin regimen initiated at least 30 days before delivery. So just a reminder that patients that we diagnose in the 3rd trimester, we should be referring them as soon as possible. That will be with either a 1-dose or a 3-dose regimen, depending on their stage, except in pregnancy, that also the recommendation is to give a 2nd dose to folks who would otherwise be eligible just for the 1 dose. So primary, secondary, early, latent, those folks should also get a 2nd dose, according to expert opinion, to reduce the risk of congenital syphilis. Normally, multiple doses are given 7 days apart, but if more than 9 days has elapsed from the last dose, they need to restart the series. The last thing I want to talk about for treatment is the Jerick-Herxheimer reaction. This is something we might see more as syphilis cases are on the rise. This is an acute febrile reaction with headache, myalgia, rash, and hypotension. It's due to endotoxin release upon treatment of syphilis. The onset is usually within a few hours of treatment, peaks 8 or so hours later, and then resolves within a couple days. But it can be associated with contractions, preterm labor, non-reassuring fetal heart tones. Stillbirth is a rare complication, but still the recommendation is for admission, for continuous fetal monitoring, for whenever treating someone after viability. So the key points here. What's new about syphilis is the increase in congenital cases. And what to do is, as sexual health care providers, we should be diligent about diagnosing and referring for treatment during pregnancy to prevent congenital syphilis. Next is gonorrhea. We'll start with some review about diagnosis. The nucleic acid amplification test is preferred. The samples can be either clinician or patient collected. These have been shown to be equivalent in sensitivity and specificity. Some patients might really prefer to self-collect, for example, folks who don't need a vaginal or a pelvic exam that day, or maybe adolescents. You can also use a first void urine or liquid-based cytology for pap smear, but they might have less sensitivity, especially if the patient has urinated recently. And remember, this is a first void, not a clean catch. We should always test with gonorrhea and chlamydia together. And kind of the only exception to the preference for nucleic acid amplification tests is if cephalosporin resistance is suspected, collect a culture with sensitivities. I just want to take a moment to talk about point of care tests. So these are rapid PCRs, nucleic acid amplification tests, or rapid antigen tests that can be done in a clinic. Usually they give a result with between 30 and 90 minutes. Typically have very high sensitivity and specificity and can often be run on self-collected vaginal swabs. This is a timeline of different point of care tests for STIs that have been developed in the past 10 years or so. You might recognize some of them from clinics you've worked in. But not all of these are FDA approved or CLIA waived, and some of them are approved, but only for, say, pharyngeal or rectal swabs. So certainly not a universal approach at this time, but really promising, and I suspect where the future is headed in terms of screening to allow for same-day diagnosis and treatment. Okay, so back to gonorrhea. Really the update here is the treatment, which is now ceftriaxone monotherapy at a higher dose. So 500 milligrams IM for a person weighing less than 150 kilos or 1,000 milligrams IM for someone weighing more. For penicillin allergy, we can be giving gentamicin and azithromycin, but just a reminder that cross-reactivity with second and third generation cephalosporins is really unlikely for patients who report a penicillin allergy. The rationale for this change in treatment is due to the emergence of drug-resistant gonorrhea. This is a graphic from the CDC showing the threat level as urgent, and about half of over the 1 million diagnoses each year are with drug-resistant gonorrhea. Here's a timeline of emerging antibiotic resistance with years since 2000 on the x-axis and the percent of gonococcal infections with resistance to the various antibiotics shown at the bottom on the y-axis. And basically, we've just worked our way through many antibiotic classes. In the past 15 years, we've had resistance to fluoroquinolone spread, and then cefixime went away when we realized that ceftriaxone was better for pharyngeal infections. We added azithromycin to try to avoid resistance, but now there's a lot of azithromycin resistance. So we're really down to just ceftriaxone. And if that fails, we might not have anything to treat. So this is one of those real world examples of why antibiotic stewardship is so important. There are some emerging potential treatments. Unfortunately, solithromycin was recently shown to be inferior in phase 3 trials. But there are a few others in the pipe that may ultimately be useful for patients with allergies or with resistant gonorrhea. But just a heads up that most of these are being studied primarily in men. So we should be on the lookout for guidance from the CDC and also be critical of the literature when we go to apply these data to our female patients. In terms of follow-up for gonorrhea, we should be doing a test of cure only if they have pharyngeal infection or symptoms do not resolve. I will admit that I did not know this prior to preparing this talk, so I'm hopeful that this is new information for some of you as well. But the CDC recommends doing a pharyngeal swab for positive patients who report engaging in oral sex. I honestly don't know anyone who is doing this routinely in practice, but would be interested in chatting more about this recommendation. We should be recommending a retest for reinfection in 3 months. Pregnant people should be retested in 3 months and or in the 3rd trimester. So usually I do this with my GBS swab. And finally, we should be making sure to notify the health department of suspected treatment failures so that they can help monitor for resistance. So the key points about gonorrhea. What's new is the increase in drug resistance, and what to do about that is treat with a higher weight-based ceftriaxone dosing. On to chlamydia. So again, here, the major update is a new regimen for treatment. Instead of the one-time azithromycin, the recommendation is now for BID doxy for a week. And to explain the rationale for this, I'm going to go through a few articles. This one's from 2015. They enrolled over 500 male and female participants with urogenital chlamydia, and they randomized them to taking either azithromycin or doxycycline for treatment. Now, importantly, these participants were housed in a facility, so they were able to directly observe either the one-time azithro or all 14 doses of doxycycline, eliminating adherence as a concern. And there were very high cure rates, 100% for doxycycline, 97% for azithromycin. So you might be wondering, why make the change from azithro to doxy if they both perform so well? And the reason for that is because of rectal chlamydia. This is a study published last year that enrolled over 600 men who have sex with men who were found to have asymptomatic chlamydia and randomized them to azithromycin or doxycycline. They found that the cure rate was much higher in the doxycycline group, 97%, versus the azithromycin group, which was only 77%. So doxy is much better for rectal chlamydia. But now you might be wondering, what does rectal chlamydia among men who have sex with men have to do with our patients who are mostly cis women? And this study is what answers that question. So here they enrolled over 400 female participants who self-collected vaginal and rectal swabs. What they found was there were very high rates of co-infection at both sites, despite low reports of recent anal intercourse. In other words, they couldn't just rely on asking participants whether or not they had recent anal intercourse in order to know if they were at risk for having rectal chlamydia. Then they treated with either azithromycin or doxycycline and found, like the other study, that there was a high rate of cure for the urogenital chlamydia, but for the rectal chlamydia, the cure rate was much higher with doxycycline. So to summarize, azithromycin is effective at genitourinary sites, but there are high rates of rectal chlamydia in patients with genital infections, and we don't have a way to screen those out by history. and we know doxycycline is superior there. Admittedly, there isn't a clear link between rectal chlamydia, persistent rectal chlamydia and urogenital chlamydia, but presumably we want to just eradicate completely, because even if you cure at the genital sites, if someone still has rectal chlamydia, they could potentially pass it back to their partner who could reintroduce it at the genital sites. So complete eradication is the goal. And finally, just because twice daily meds for a week is less ideal in a lot of ways than a one-time dose, I want to go over the advantages and disadvantages of azithromycin versus doxycycline. So of course, for azithromycin, the benefits are directly observed therapy. They can be given on site with no need for the patient to go to a pharmacy, offering more privacy from partners or parents. The drawback is the lower cure rate for rectal chlamydia. Of course, the benefit for doxycycline is a higher cure rate for rectal chlamydia, but the drawbacks are concerns about lack of adherence. Taking 14 pills instead of just 1 or 2, and an increased risk of pill esophagitis. So ultimately, we should be using shared decision-making with our patients. If adherence is really a concern, it is appropriate to use azithromycin, but then that patient should undergo a test of cure. The CDC also recommends that clinics dispense the entire week's worth of doxycycline and observe the first dose, but that's just not possible for most of our practices. So use shared decision-making and make the best choice for the patient. The key points for chlamydia: what's new is the recognition of rectal chlamydia as prevalent and the superiority of doxycycline cure at that site. So what we should be doing is treating our non-pregnant patients with doxycycline 100 BID for chlamydia. Next, to trichomoniasis. So for the diagnosis, there is no universal screening recommendation, but we should be liberally testing patients at risk with nucleic acid amplification tests. If there's concern for resistance, you can order an in-pouch culture medium from the CDC, which is what's shown on the left here, to send for further testing. That will take a little bit to come back. So in the meantime, just keep escalating treatment, often all the way to oral plus vaginal tinidazole. But you can get culture and susceptibility data that way. Again, the new thing here is a change in the treatment regimen. So for women with trichomoniasis, the recommendation is no longer the one-time dose of metronidazole, but 500 BID for 7 days. The recommendation has not changed for men. This comes from data from a randomized trial in which 600 female participants with trichomoniasis were randomized to either receive the 7-day BID dosing or the one-time dose of metronidazole, and they were then retested a month later. And those who were in the 7-day dose group were more likely to be negative than those who were in the single dose group. Since men were excluded from this study, we don't have any data about them, and that's why the recommendation hasn't changed for them. So the key points here, what's new is the data showing the superiority of 1 week of metronidazole over a single dose. And so that is how we should be treating our female patients. Next is PID. And once again, the update here is a new treatment regimen, and this time it's about the inclusion of metronidazole. Essentially before, where it was plus or minus metronidazole, it is now recommended to include it. Here's a table of recommended parenteral regimens of PID, which is cephalosporin and doxycycline, now with the addition of metronidazole. Similarly, the intramuscular and oral regimens include metronidazole. For patients with an allergy, gentamicin and clindamycin also work. And also just to note that these treatments are listed alphabetically, but they are all equivalent. The support for this change comes from trials showing improved outcomes with metronidazole. So this one took over 200 female participants with PID and gave them all ceftriaxone and doxycycline, and then some of them received metronidazole and some did not. There was no difference at 3 days, but at 30 days, those who had received metronidazole were less likely to have endometrial anaerobes, pelvic tenderness, or M. genitalium, which we'll talk more about in a minute. A few other points about PID, a reminder that IUDs should not be routinely removed. that outpatients, either patients who are discharged from the hospital or primarily managed as outpatients, should be reevaluated in 3 days. Sex partners from the last 30 days should be evaluated or just treated for gonorrhea and chlamydia, even if the person with PID has negative cultures, because there's the thought that the organisms can be higher up in the reproductive tract. And then also these patients should be retested 3 months later. So the key points here is what's new is the data showing the benefits of metronidazole. So go ahead and add that to the regimens. Okay, a quick review of expedited partner therapy. I know not everybody on this call is from New York, but the majority are. So this is New York specific information, but I was able to access it pretty easily through the Department of Health website. So if you're in a different state, I would just encourage you to find that resource because the rules do vary state to state. But in New York, expedited partner therapy is legal for gonorrhea, chlamydia, and trichomoniasis. If the partner is unable or unwilling to come in for IM ceftriaxone, then cefixime PO is an alternative regimen. While inferior, it is better than nothing. If you have the partner's name and date of birth, then you can just call in or write a script for them. But if you do not, you can write for first name expedited, last name partner with a date of birth of 1/1/1901 and write expedited partner therapy in the notes field, and the pharmacy should dispense it. And it is okay to prescribe to minors. Okay, next is Mycoplasma genitalium. I'd like to start this section by telling a little story. I had a patient a few months ago, a patient of our practice who had gone to an outside hospital ED with acute pelvic pain. And they drew an STI panel, which did not result while she was there, but showed up on her portal, and it showed that it was positive for Mycoplasma genitalium. And she came to me asking what she should do and requesting treatment, having almost thrown her partner out of the house after discovering this. So this was kind of a crash course for me in learning about this bug that I don't know very much about. So let me educate you on what I learned. Mycoplasma genitalium is a common cause of non-gonococcal urethritis in men, but relatively less is known about the disease in women. There are data showing associations with cervicitis, PID, infertility, miscarriage, and preterm birth, but really there's just not a lot known. And because women share both the health and financial burdens of STIs in general, there is a need for prioritizing research on this organism in women. So in terms of the diagnosis, there is a nucleic acid amplification test, but be aware that there is wide macrolide resistance, which you're not going to get data about that from the nucleic acid amplification test. In fact, you're probably not going to get data about that at all because a culture takes months, so it's only available in research settings right now. There are some molecular markers of resistance under evaluation, but they aren't in practice just yet. Because of this, screening of asymptomatic people is not recommended. So I encourage you to beware of STI panels because some of them include mycoplasma, which maybe is not what you intended to send for. So here's an example of the cervicitis panel from Quest. I imagine this is actually what happened when that ED provider sent this for my patient who didn't really meet criteria for sending for this. This is recommended by the CDC to test for Mycoplasma genitalium in cases of recurrent cervicitis or to consider for PID, which my patient did not have. So now I was really in a pickle with this patient because I had a positive result in an asymptomatic patient and no resistance testing. So let's look at treatment options. The recommended regimen, if resistance testing is available, is to start with doxycycline that helps to reduce the organism load and facilitate clearance, and then to follow up with either azithromycin or moxifloxacin. The problem is that with macrolide resistance, moxifloxacin will often be necessary because routine testing is not being done. So then we're left with moxifloxacin by default, which is the situation I was in with my patient, but I couldn't get insurance to cover that medication for her. So we were left in a situation with no resistance testing and no access to moxifloxacin, in which case the recommendation is doxycycline, then azithro, and then doing a test of cure. So the key points here, what's new is kind of this bug. It's an emerging pathogen that we don't know very much about. So we should be just on the lookout for more guidance in the coming years. Okay, so we've hit on most of the big things. I just want to go over a couple of updated guidance points. First, about Hep C. You're probably all aware of this, but the CDC now recommends one-time Hep C testing during each pregnancy for all pregnant people, and both ACOG and SMFM have adopted this recommendation. And just so you know, there are pediatric clinics that will manage neonates that have been exposed to hepatitis. An update about metronidazole and alcohol. So kind of longstanding dogma has been to tell patients to avoid taking alcohol or avoid drinking alcohol when they're taking metronidazole. But this recommendation was always based on pretty weak data. And a closer look at that data has led us to the conclusion that it's not necessary to abstain from alcohol during treatment with metronidazole. I know I certainly have had patients who I was treating for post-abortion endometritis who had social events coming up like bachelorette parties or weddings, and they were just determined that they were going to be drinking. So I would much rather them drink and take their metronidazole than skip doses of their antibiotic, especially without good data to make that recommendation, just something we probably do not need to be doing. And then fluconazole in pregnancy. So there is evidence of increased risk of heart defects after first trimester exposure. So we should be using topical antifungals definitely in the first trimester and perhaps throughout all of pregnancy. So this is all of the things we talked about. I want to just do a quick review, and then we are going to have plenty of time for questions. So for syphilis, because of the increase in congenital cases, as women's healthcare providers, we should diligently screen all pregnant people so that we can identify and treat and reduce the risk of transmission. This is also, by the way, the recommendation for hepatitis is screening all pregnant people. For gonorrhea, because of the increase in resistance, the treatment has changed to ceftriaxone 500 to 1,000 milligrams IM. For chlamydia, because of the recognition of rectal chlamydia and the superiority of doxycycline at that site, the new recommendation is doxy 100 BID for 7 days. For trichomoniasis, because of the data showing the superiority of 1 week of treatment, the recommendation is now metronidazole 500 BID for 7 days. For PID, because of the data showing superiority of the addition of metronidazole, we should be adding that to our regimens. For Mycoplasma genitalium, at this point, just be aware of it. Metronidazole and alcohol, no need to abstain from alcohol, and we should be avoiding PO fluconazole in pregnancy, especially in the first trimester. And that is everything I wanted to tell you about. So I see we have a lot of questions, and we will be getting to those now.
Thank you so much, Dr. Tall and Dr. Burstein. That was a fantastic presentation. We did get a few questions, but if anybody in the audience has questions, there is a Q&A tab, and you can just type that in there. The first question we have is for EPT. Can we write extra refills or doses on our patients' prescriptions so that they can give it to their partners?
That is a great question. That is actually not okay to do, because in that case, you are indicating that it's for the patient and billing to their insurance. So unfortunately, that's insurance fraud. So that's why these rules to try to make it as easy as possible to give it to someone else, even if you don't have their contact information.
Great, thank you. Another question that came up is, does each state have different laws on testing for syphilis in pregnancy? I think we have several people attending from many different states beyond just New York today.
Yes, every state does have different rules. I think at this point, most states allow, or it's either recommended or permissible to treat for gonorrhea and chlamydia. There is a variety in treatment of trichomoniasis. Dr. Burstein, anything else to add about that?
Yeah, each states have different laws just about what you can do for expedited partner therapy, what minors can consent for their own sexual health care. Some states like New York and California don't have ages on those laws. So if you feel that you're even talking to a 12, 13-year-old and you feel that they have the cognitive ability to provide informed consent, you can provide them with the confidential services and that personal health information cannot be shared. Of course, with a 12 or 13-year-old, you may want to contact Child Protective Services because it could be something funky going on. But anyway, you don't have to, disclose to, a parent or guardian. Whereas other states, more so in the South and the Midwest, have ages on those laws for minor consent that could start at 13, 14, I think 14 or 15 could be the highest. Good place to look at that is ask your local health department or state health department. Also on the Guttmacher Institute's website, they actually update they update state laws around minor consent issues every month. So that's current, and you can always go to that. And then for any questions around what is mandated for testing during pregnancy and reporting to a health department, you can always contact your local or state health department for that information. I think as a health commissioner, I can say that health departments really want to work with community providers. Many times it's not in their comfort zone. They don't have the contacts. So if you're reaching out to them, usually they're very appreciative and very happy to work with you.
Thank you. The next question was about herpes. We got a few about that. And I think the question was really, are there any new updates from the 2021 guidelines? Because we didn't really cover that topic today.
I don't believe there are new guidelines.
Yeah, I think, basically the guidelines are very similar.
I can certainly, since it seems a few people are interested in that, put in a couple of slides, just a reminder about diagnosis and treatment for the slide deck that we share with people.
That would be great. Thank you. There was a question, and the question is, if a case diagnosed with GC fails to return for treatment, had been pre-treated with doxycycline 100 milligrams BID, concerned if treatment for Rocephin is still needed.
So doxycycline is not one of the recommended treatments for gonorrhea, so that person should return. If the doxycycline will cover chlamydia, which is great to cover if you don't know their chlamydia status, but if they're not willing to return, they should be getting a cephalosporin, so piosulfixime, not doxycycline, would be the recommendation to cover for gonorrhea in the case that someone can't access or doesn't come back for Rocephin.
And if I can add, if providers are having difficulty getting their patients back to get treated, you can also, that's something you can work with your local health department, let them know that you have a patient that was diagnosed with chlamydia or gonorrhea or syphilis or HIV, and you can't get them back for follow-up. And many times the health departments will deploy there's disease detection folks and to find them and make sure they can get treated in the field.
Great, thank you. Another question was, how do we work with the health department to ensure our patients are treated and partners notified? And I know, Dr. Burstein, you spoke a little bit about this previously.
Right. Well, first of all, it helps us at the health department immensely if providers can report the communicable diseases that they diagnose in their office. So for many states, including New York State, there's an online form you can complete. Sometimes you can just call it in. We have agreements with some providers that every week they can just fax in a line list of patients that they diagnosed and what the communicable disease was and what they were treated with, or if they were unable to be treated. So we're communicating with the health department is really important to make sure that our community is treated. And then also we'll have that information so we can help locate partners if you're not able to offer expedited partner therapy. Again, if you have patients that you can't get back, or you're worried that their partners will not get treated, contacting the local health department, or if you're sometimes the state health department covered those areas in certain rural areas. So I'm reaching out to your health department to help you with your patients that you can't get back for treatment, or making sure that their partners are notified, is something that most health departments, really want to work with providers on. So please call us.
Thank you. Another question was, will the CDC app get updated from the 2015 guidelines, or is a new app being published? And I could answer that. So they are publishing a new app. It is not yet posted on the CDC website, but they hope to be finished with that in the next month. So hopefully by the end of May, there will be a new app on the CDC website. That was actually our last question. I will sort of, give it another minute if anybody wants to ask any other questions, or Dr. Burstein or Dr. Tall, if there's any other points that you wanted to add.
I just want to add one more comment that questions I often receive for providers about the legality of expedited partner therapy. I think that providers, depending on what your state laws are, may feel uncomfortable about giving medication to somebody they've never seen, or writing a prescription for somebody they've never seen, whether or not they need to know the name or not. But however, if looking up what your state laws recommend or allow, either on the CDC's website or contacting your health department, is important. And you should try to maximize those opportunities for partners to get treated, because you're preventing reinfection for your patients. So actually treating the partners is actually a preventive therapy for your patients. So I just want to reinforce that, because that's why we recommend a test of reinfection between 1 and 3 months after a patient is treated for gonorrhea, chlamydia, or trichomonas, is because many times those patients are reinfected by their asymptomatic untreated partners. And so this is really an advocacy action for your patients, not only for their partners, but it's really to help your patients stay free of infection.
Dr. Burstein, you were mentioning that you had a hand in coming up with this, being able to put in first name expedited, last name partner, and that actually for folks who have an electronic medical record, you can create a chart for this person with that first and last name and a date of birth of 1/1/1901, so that you can electronically send in prescriptions for that person, which is great, because we don't have paper scripts around anymore. So it's very hard sometimes to hand the patient a script, but sometimes the patient is reluctant to have us initiate treatment for that partner because she's worried the pharmacy is going to call the partner and tell them they have prescriptions before she's gotten a chance to have a discussion with them. So, I think the work you've done, and we should also be really diligent about offering to mediate those discussions with partners, and kind of empower the patient to, however we possibly can, help her get treated to protect herself after she gets treated.
Right. Thank you, Lonnie. And we've, we use the dummy patient expedited for the first name, and partner therapy was the last name, in our pediatric clinic, and, to send electronic prescriptions for Azithro and Doxy electronically, and it worked. What we did is after we sent the e-script, we called the pharmacy just to let them know what it was, because that it's kind of a weird name for a patient, expedited partner therapy. And then pharmacies are also legally, they can fill that prescription. So sometimes you just need to give them a friendly reminder that this is something that is legal for them to fill.
You can tell them, just Google FAQ NYS EPT, and that really nice frequently asked questions booklet that I had a screenshot of will come up and show them, you know, that they're protected and that in fact they should do it. So.
Great. Thank you so much for those added comments.
Oh, I just have, sorry, one more pearl. When, you know, I've found with, especially treating my adolescent patients, when I've tried to do a test, call patients back for a test of reinfection, if I waited for 3 months, I had great difficulty with patients accepting that the idea of returning for a repeat test. You know, it seemed like they had amnesia, like chlamydia. What's that? Did I have that? I don't remember that. But if I contacted them in a month and said, okay, in another couple weeks, I want you to come in, or I'm going to send it for a retest, or I'm going to send in a prescription for you to, you know, submit a you know, urine specimen for another test. I had much higher uptake in that. So, you know, I know that the CDC guidelines recommend 3 months to wait, but again, with our younger patients, you might want to just maybe wait, you know, a month and a half instead of waiting the 3 months.
Great. Thanks so much, Dr. Burstein and Dr. Tall. I also want to point out a resource that has been posted in the chat box. It's the National Clinical Consult Line around STIs. And so it's a service that we provide for free, and it's really for clinical providers. If you have questions about patients, cases, you can submit your question online and we will get back to you in the next 2 to 5 business days. There's no patient information put in, so everything is anonymous in that sense. But we really encourage and welcome you to use that resource. And I'll add that we will be sending out an email to all participants today that will include the slides, and we'll include some information on herpes in those slides. And we will also be sending out instructions on how to access your continuing medical and nursing education credits. But we'd like to thank our 2 speakers, Dr. Tall and Dr. Burstein, for joining us today and giving an excellent presentation. And also thank all of you as participants for taking the time out of your busy schedule to join us today. We hope to see you on a future webinar, and thank you.